All right. Hello, everybody. Good to see you. We've still got some folks coming in, so I'll keep bringing people over. I won't have too much to say at the beginning before we jump in to some more specific topics. So here's our agenda for today. Want to talk a little bit just process-wise about the objections log, make sure everyone has access to the first draft of the report and understands how to use the objections log. And then that also will involve us. If you took a look at the objections log, you might have seen that there were some, and I think we had talked about this at the beginning, this idea of assigning some leads to read the plan with a very specific, read it with a very specific kind of viewpoint in mind. And so we needed to go on and figured we could go on and assign those leads now. So specifically about the objections log, the purpose of this is just so that we can keep, I just find that, there's like lots of conversations going on, and definitely, some points of feedback might be more salient or might stick out more than others as we're trying to, craft this document that we're ultimately going to share. And I find that an objection log works best just for organization and transparency. That way we know what objections were raised. It's okay if we don't keep who raised them specifically, but knowing that objections were made and then what the recommendation was, because then we can, very clearly tell, were we, look, this was recommended, but it didn't make it into the plan, right? Just so that we can kind of have that running log. And also just from an organization point of view, just so that we're not having too many people editing in the document itself. And also so that we're not focusing too much on more like personal preferences, right? By the time you have to kind of think about it and frame it as an objection, it just puts you in a little bit of a different frame of mind versus, I like things this way and you like things that way, right? When you have to frame it as an objection, you can be a little more clear about what exactly is the problem. And whether you have recommendations for the solution or not, that's okay. Ultimately, we will need recommendations for each objection, but it's okay to raise an objection even if you don't have a solution. That's totally fine. It's not on you to solve, you don't have to solve the objection you raise, but that's the purpose of the objection log. And so some of the lenses, and I actually believe that we had started to, in a way, assign some of the lens readers earlier in the process. So if you think you already kind of volunteered for something, please just kind of re-volunteer, because I don't know that I really tracked that in a very formal way. So some of the lenses that we know we wanted to apply to the whole plan were developmental disabilities specifically, youth specifically, involving peers across the entire process specifically. 1, 2, 3. I know there's more. I put a couple on the objections log, so you can also put them in the chat if you're thinking of some lenses. Equity was a lens we wanted to read the whole plan with. So if anyone either would like to volunteer now or feels that I'm thinking of the peer one specifically. I feel like after that presentation, there might have been a volunteer to look at the whole plan through that lens. So if you want to put in the chat if anyone wants to volunteer as that lens reader, I would recommend we do that after the second draft, which is going to come pretty quickly. But there are a couple kind of structural changes that have already been suggested that I don't want anyone to, take the time to edit text that is that might be changed. So let's see. So I don't see anything in the chat yet. That's okay. But yeah, just as you. Oh, okay, awesome. Thank you, Chloe. So Chloe's volunteered to do the youth lens. Perfect. All right. Yeah, so you can think about that. And if we don't have volunteers for each lens, we'll send an email out to the full group and see what we can do. All right. So the main presentation today, as far as, sort of the more substantive, oh, thank you, Catherine. The more substantive presentation we have from the Equity and Safety at Intercept Zero group. So that's gonna go first. And then we do have some recs from more of the process groups, but they're more, they're not really full presentations. It's more like a single slide kind of update thing, or it's a couple of slides for local roadmap. And so I'm hoping that between those two things, depending on what time we finish that, it would be great if we have a time for a full round to get, any reaction from everybody. It's okay if you haven't read the whole plan. It could be either any general reactions that you have or anything about process, or if you've had a chance to read it. I'm hoping we can have a round to let everyone weigh in. I think we should have time for that. And if not, we can, have people volunteer to do that. Oh, Catherine, you said you thought you were third. Yeah, I realized that the community input group, just since it was the single slide, I had put it down one lower. But yeah, if that's it's the next slide if we want to go on and do the community input group, and then we can move to equity and safety. That works for me. Okay, perfect. All right, so Atasha, are you on the line, I believe?
Yes, I'm here. I was having some technical difficulties. How's everyone doing? Can you all hear me? Okay, because I was saying hello. Okay, too much happening today. How is everyone? So one of the things that we talked about with the community work group, just to kind of go back into last meeting, was that we noticed that there was just a glaring gap. And instead of it just being viewed as a gap, we're really looking at it as an opportunity to continue connecting with the community. We found from just the listening sessions and then the surveys results that were read, was that members of marginalized communities, the BIPOC community, were really underrepresented. And so we felt it important to acknowledge that perhaps we still had just not been able to establish that trust just yet. And so we discussed creating the focus groups. And so one of the purposes for the focus groups or for town hall meetings is to be able to create an even smaller space for individuals who might feel like they don't know if they can trust the work groups just yet. And we have to understand and acknowledge that. So we also talked about town hall meetings and making sure that we're able to partner with organizations inside communities to really serve as that community cultural broker, to start establishing that trust. So for example, if there is a nonprofit that we know does some really good restoration work, returning citizens work, to make sure we partner with them to have them really be that community broker and cultural broker for us. And we wanted to increase and continue the listening sessions. We found that the listening sessions were extremely helpful and that the listening sessions modeled or mimicked what we saw in the results. So it's possible that if we bracket that out into our BIPOC communities, perhaps what's discussed in the listening sessions would also look like some survey results, because again, there's an entire population that's missing. Another recommendation of our committee, and we're meeting on Friday to really hash everything out, but another recommendation of our committee is to consider specialized groups and flesh out more town hall meetings, focus groups based on that. So we know since the inception, we've had discussions between mental health, the IDDD community, and substance use. And so we know that there are peer specialists who specialize in each of those areas. There are clinicians who specialize in each of those, and then interest groups as well. But what can happen is that there could be one voice that speaks louder, and we don't want any group to feel intimidated and that they don't have a voice. So if we bracket out each of those demographics and specialized groups, then hopefully we'll be able to get as much information and support as possible. And again, I think the biggest part in our recommendation for the subgroup, and this really, we've talked about this, it just kind of took off as far as the community group. I don't think we necessarily thought we would have to continue post the initial listening sessions, but again, we really found that there were populations that were missing. And when we think about the impetus for the Marcus Alert, for the act, we have to make sure that we are not leaving out those communities of color. And we have to make sure that we're very intentional with our communication. We have to make sure that we're not leaving out vulnerable populations. And while we definitely heard from impacted individuals, family members, support systems, professionals, advocacy groups for some demographics, we really want to make sure that we can hear from all. And hopefully there'll be some individuals who will volunteer to serve alongside us. I really do think that we will have that, especially from the community stakeholders, cultural brokers, so to speak. I definitely think that we'll begin to have some participation, because I do acknowledge that even for some of our smaller groups, especially because some of them are often peer-led, there could be a criminal justice component, there could be a criminal history component, there might be some hesitancy and some distrust. So it's really important for our community subgroup that we model that. I think that we've been very intentional in making sure that our communities that are participating feel safe and feel heard. For anyone who did not attend those listening sessions, they were very intentionally orchestrated. You know, this was very much like a conversation. And so an individual would share their insight, and then we would really repeat that and recap that for them to make sure we heard it. Because we know for all of these communities, there has been a sense of feeling unheard. And so that's a major part for us. We've been very consistent as a subgroup with those recommendations. We've been very consistent with making sure that we have that standard. And so I think that that is a really good next step for us to take to make sure that we're able to bring in some of those smaller agencies, those smaller nonprofits, especially those who are directly in the community, who are then able to post-COVID, you know, begin to identify areas throughout the Commonwealth where subcommittee members can visit and attend. We know that the physical presence is really important, and we know we've lost much of that during COVID. And so, you know, we use the several sessions of town hall meetings to be able to meet that need in the listening sessions. And I think as the country, as the Commonwealth is beginning to open up, some physical visibility in communities will be so important to make sure that all members are feeling heard and feeling that we are invested in making sure that they are safe. And I don't know if anyone else on the sub, I know I was just speaking with Sabrina, so I think I echoed what she and I were both conveying.
Perfect. All right, thanks. Does anyone have any questions about the community input subgroup? Or for the community input subgroup? All right, well then I will stop sharing my screen. And Catherine, you're gonna share your screen during this?
Okay, I'm just gonna switch over.
Perfect. Let me know if it doesn't, like if I don't have it set up.
Okay. Yeah, it's not. Can you try it again?
Try now.
Okay. Okay, can you guys see it now? Yeah?
Yeah.
Okay, excellent. All right, so we are, well, I'm presenting for the Marcus Alert Equity at Intercept Zero, and these are the recommendations that we made. I'm Catherine Hawks, and I've served as lead. Additional group members have included Daryl Frazier, Ryan Banks, Sarah Wilson, Atasha Christian, Sabrina Burris, Mark Blackwell, Chloe Edwards, Nikki Fadley, Bruce Cruiser, Eric Blevins, and of course, Lisa Job Shields. Thus far, we have met a total of 4 times. So March 17th, March 24th, April the 7th, April the 14th, and have had significant communications during that period of time and afterwards as well. Okay, so in the last decade, there have been numerous advances in behavioral health policy. However, problems still plague the behavioral health system as mental illness and substance use persist in the United States. As the nation experiences a reckoning in systemic racism, the need to address persistent adverse behavioral health outcomes for minority communities has become even more apparent. Through implementation of the Marcus Alert, we aim to provide Virginians equitable, safe behavioral health responses to their behavioral health crises. Behavioral health improvement requires an emphasis on equity and prevention with high focus on a community-based model that initiates care being brought to individuals in need to focus on improved outcomes. There must be particular focus on equity and safety to ensure the most optimal outcomes, and particularly among Black and minority populations, which consistently experience adverse outcomes during crisis responses. Currently, Virginia's behavioral health crisis responses need improvement, as law enforcement have historically been the de facto response during behavioral health crises. As previously discussed in prior stakeholder meetings, law enforcement responding to such crises is generally escalating, unpredictable, and high stress. In a recent study conducted by Columbia Law, an analysis was conducted on 3,933 killings to examine the intersection of race and reasonableness in police killings. This study was previously referenced. However, we will specify some findings from this study to aid in understanding the context of equitable crisis responses and which population is the most disproportionately affected. They found that across several circumstances of police killings and their objective reasonableness, Black suspects were more than twice as likely to be killed by police than persons of other racial or ethnic groups. Even in circumstances where there are no other circumstances during the encounter that would make the use of deadly force reasonable. In this table, we see there's a significant elevated risk for Black people suffering a mental health crisis. Black civilians were 3.4 times more likely to be killed than white civilians. Overall, the study identified 2 worrisome findings. First, training protocols focused solely on mental health may need to be redesigned to incorporate lenses of greater perceptions of threat among Black civilians. Secondly, race may be more salient than other factors in the decision to use lethal force on a suspect across circumstances. Police killings are found to be neither race neutral nor correlated to specific features of the incident, suggesting that race may be a multiplier of reasonableness that elevates the risk of police killings for Black and some Hispanic persons. The initial implementation flowchart is as displayed, which includes DBHDS, committee stakeholders in the equity and safety subgroup, committee stakeholders in the community subgroup, and regions 1 through 5. We've had community listening sessions and community surveys, which have been largely the effort of stakeholders in the community group. And then, of course, DBHDS has defined the problem, assigned state stakeholder planning members. And then in the equity group, we have established scope and goals, developed a proposal, or are developing a proposal. And the next step is to approve the proposal, integrate it into the statewide framework, which is of course purview of DBHDS, develop a specific local plan, and that will be for regions 1 through 5. The plan must then be approved, and then implemented, and then assessed and reported. And so there's some specific steps that we recognize, and of course we want to define leadership, project scope, risks, roles and responsibility, and considerations for multiple site implementation. So as previously stated, leadership is polycentric. You guys can see in this chart where we show that there's federal agencies. So we have the Virginia Department of Behavioral Health and Developmental Services, the Virginia Department of Criminal Justice Services, the state of Virginia and each locality, CSBs, the statewide stakeholder planning group, which is a multidisciplinary team comprised of mental health partners, law enforcement, emergency management, racial and social justice advocates, and other community partners. So vision for Marcus Alert at Equity at Intercept Zero is to decrease adverse outcomes from mental health responses, increase safety through empowerment, increase safety supports, develop standards for all providers, increase equitable access to behavioral health services, and establish mobile crisis services that commit to do no harm. Some preconditions also exist, which are to be based on national best practice models, must align with the Crisis Now model, which implements collaboration with law enforcement, must intersect with STEP Virginia, and must be composed of a crisis call center, a community care and mobile crisis teams, crisis stabilization centers, and the Marcus Alert system. Functionality is also important to consider. Both rural and urban areas must have the ability to frame their local plans to their region and be able to identify specific geographic needs and community needs. Functionality will ensure that the Marcus Alert is feasible throughout each region in the Commonwealth, not just the first 5 initial localities. With this in mind, we identify 4 main areas for the project scope, which are training and quality improvement, funding, safety, and networks. And then we also identified specific measurables for what we were going to work on. So these are actually some pretty comprehensive lists. And so I'll go ahead and read them. Make recommendations and identify necessary training for all providers. So that's behavioral health, law enforcement, dispatchers, and other first responders, and review utilizing an equity lens proposals from other groups that relate to training mental health, law enforcement, and dispatchers. Make recommendations and designate specialized and or advanced training for all providers, and review all proposals from other groups that relate to advanced specialized training utilizing a mental health and equity lens. Consider and make recommendations about any special training or certification programs to be developed as part of the Marcus Alert, and identify if a special designation would be helpful. Make proposals to designate an oversight committee or body to ensure equitable and safe practices at Intercept Zero. Identify if a state oversight body, a function of networks, or some other mechanism of ongoing quality improvement in regard to equity at Intercept Zero should be established. And then make recommendations regarding continuity of care and whether this should be a part of the state plan. And so based on those items, we made some specific recommendations. So these are listed here. And the first recommendation was that we recommend and identify that there needs to be necessary training for all providers. So not just mental health, but mental health, law enforcement, and dispatchers. And to review, utilizing an equity lens, proposals from the groups in regard to that. We recommend standardized training statewide for all providers. All providers must be held accountable. Therefore, standardized training must be established at the state level for all providers. Additionally, we recommend a comprehensive approach with a mix of a training program and smaller workshops. This will allow us to be able to get training in implicit bias, anti-racism, disability justice, and cultural competence. Any existing training that is required as part of that provider's specific program is not a substitute. So this is mandated. We recommend mandated specific training. Also, an MOU for partner organizations must include the specified training that they've utilized, and they must produce completion of that training. So an abundance of training programs and workshops exist, yet very few have systematic reviews and or are evidence-based, demonstrating measurable outcomes. We conducted in-depth research into various training programs and workshops. Criteria consisted of the following: evidence-based with preference placed on programs and workshops with systematic reviews or meta-analysis, ability for ongoing development and continuing education, tracking metrics or supplement with separate tracking program, and no check-the-box training. As a result, we identified paradigm, visions, undoing racism, creating accessible neighborhoods, and the Trauma Resource Institute. So we recommend Paradigm as the main training program for the following reasons. It is an evidence-based, data-driven, and action-oriented program that has been implemented in various organizations, ranging from Fortune 500 companies to small community-based organizations. They have an interdisciplinary team consisting of organizational psychologists, diversity and inclusion experts, and data scientists. They provide a host of services, which include consulting services, interactive workshops, and an e-learning program called Paradigm Reach. This provides a nice mix of in-person consulting, live workshops, and online learning addressing implicit bias, cultural competency, and anti-racism. They also provide diversity benchmarking and reporting. Our subgroup identified the need to track all training, and through Paradigm, there is the ability to track each individual person's training. This eliminates the need for additional tracking software or a paper trail, which can become cumbersome. Additionally, they provide proprietary algorithms and analytics tools quantifying unstructured data and identifying trends. Lastly, the program is affordable, and it's priced in tiers depending upon how many people are in need of the training within the organization. This is affordable for long-term continued development. Visions is the next program that we recommend. This is a workshop. And so the workshop can be added to the broader training program. An external survey conducted of participants in the Vision program reported 94% agreed the diversity and inclusion training excluded their initial expectations. Visions is based on modern racism and reinforces transactional theory. They have several workshop offerings: personal approach to change and equity, also known as PACE, in level 1 and level 2, youth engagement, internal capacity building, ongoing skill building, ongoing supervision, and transactional analysis training. We also identify Undoing Racism workshops by the People's Institute for Survival and Beyond, also known as PISAB. And it's an additional workshop that can focus on anti-racism. It is an evidence-based program with a host of peer-reviewed studies demonstrating improvement in racial attitudes. It is based on undoing internalized racial oppression, increasing knowledge and awareness of the history and impact of racism, power, privilege, and oppression on community systems. It largely focuses on the lived experience of being Black in America. Our subgroup did overwhelmingly communicate the need for lived experiences and training. Undoing Racism provides workshops, consulting, and a youth agenda. The next program we identified is Creating Accessible Neighborhoods. So Creating Accessible Neighborhoods is a Canada-based organization, but provides workshops throughout the US as well. During research, we found that there was a lack of programs that truly encompass disability justice. Some of the above programs, some of the other programs I discussed do have a disability justice component, but does not actually have training that is comprehensive on disability justice. They focus on disability justice, disability awareness, gender and sexuality, and imposter syndrome. And they provide lived experience workshops and consulting services. They are well known for their work in the community and beyond, and are very affordable, being the least expensive workshop identified. Considering the identified need for lived experience when providing disability justice training to address the lack of workshops, programs, it would be beneficial for regions to consider lived experience advocates that provide consulting and workshop services. As seen on this slide, these are two very well-known lived experience disability justice advocates. Alice Wong is the founder of the Disability Visibility Project, and Imani Barbarin is founder of Crutches and Spice. Each provide consulting services across the US. We also identified the need to have trauma training and recommend the Trauma Resource Institute. They have an evidence-based training with peer-reviewed studies demonstrating statistically significant decreases in the average number of depression, hostility, anxiety, and somatic symptoms. 90% of respondents either completely or somewhat agreed that CRM skills were useful. 98% reported being moderately to very satisfied with CRM training. And their program offerings are trauma resiliency model, that's level 1 and 2, and the community resiliency model. They're also very affordable. So the need for de-escalation training was also identified. There's a lack of de-escalation training offerings separate from CIT. However, one of our subgroup members was able to connect with Cahoots, which provides de-escalation training through the Whitebird Clinic. Many of us are aware of the success of Cahoots and therefore recommend their program. It is based on a client-centered model upholding personal autonomy. User approaches include being able to communicate to a layperson, personal safety, and recognize when others may need help. It has been offered to a range of organizations, including governmental, community, and EMS groups. Continuity of care. To address continuity of care, we recommend Unite Us. Unite Us recently partnered and has been implemented in Virginia to ensure patients receive adequate services throughout the continuum of care. They largely focus on the social determinants of health, and they have a very robust referral system. So this could enable referrals to be made in a very easy way. They have a tracking system, and it won't involve anyone having to actually build out their own tracking system. We also identified a need to establish a sense of patient autonomy and dignity at all times. This includes the release of body camera footage. So if body camera footage is released, we recommend blurring identity of individuals to protect their privacy. Additionally, crisis teams must provide language access, adaptive approach, but it must specify what they're going to do to provide language access. So specific steps in regard to funding. So we identify for the project scope that there needs to be a review of Medicaid criteria for mobile crisis teams for December the 1st, identify concerns or issues and ideas for mitigation, make recommendations for requests for proposals that would support the network and coalition that will be described, as well as making recommendations for other requests for proposals such as startup funds for crisis providers. In regard to funding, we identify the need for identifying funding for staffing, equipment, and training. So the overall Marcus Alert budget consists of the following. The call center staff is $4.7 million. The adult mobile crisis is $6.1 million. $3 million for Marcus teams and Marcus Alerts. $600,000 for each region, 1 FTE at central office, and 1 FTE at the Virginia Department of Criminal Justice Services for Marcus implementation. There will be crisis-specific startup funds for community providers that have a relationship or participate in dispatch infrastructure with mobile crisis hubs and want to provide crisis services, including the new Medicaid benefit. A particular focus will be placed on Black, BIPOC, and peer-led providers. The startup funds budget is $600,000 with 8 $75,000 packages. Additionally, there will be specific funding for 5 organizations or sites that must be clinical or have a close connection to a clinical agency that bills Medicaid. Training clinics are also eligible for funding. However, they must have licensed supervision. The clinical funds budget is $1,050,000 with 7 $150,000 packages. In addition, we specified that the community outreach budget totals $25,000. So human resources are, of course, a critical long-term resource. Staff will include 2.5 FTE internships, $20,000 each position, and possible fringe benefits. The positions will entail 1 community network facing position and 1 research data facing position, 1 FTE position or 2.5 FTE peer positions, totaling $50,000 plus fringe, totaling $65,000. 1.5 FTE academic or nonprofit staff can also be donated in kind, $30,000. Equipment is another long-term resource and will include laptops, GPS tablets, smartphones, vehicles, either repurposed or new, software to track training, and if Paradigm Reach is implemented, then you won't need additional training tracking software. Also, training is typically considered short-term in regard to resources, but we recommend ongoing development and ongoing training. So that will be another long-term resource. GPS alternatives may be needed for rural areas as most may have low or no internet access. And so keeping teams safe is imperative. So if GPS devices will not work, another way of tracking should be implemented. So in regard to safety, the project scope that we identified is to make recommendations for Marcus Alert teams that are not mobile crisis. So community care teams without law enforcement and community care teams with law enforcement. Examine recommendations from other groups in regard to community care teams involving law enforcement to identify other safety supports, and assist with defining best safety practices to mitigate risk, including but not limited to no force first approach, both in terms of Intercept 0 as well as responding to the other group proposals at Intercept 0, 1 or 1. So the co-response must include no force, non-lethal, and unobstructed cameras for all law enforcement that must be turned on at arrival. A list of specific strategies to slow down interactions when law enforcement arrives on scene. There was some discussion about law enforcement waiting in vehicles, and most of law enforcement expressed that they did not feel comfortable with that, not knowing what was actually occurring on the scene. So some alternatives are to have a clinician on the phone or via telehealth with law enforcement, so law enforcement can approach, but is accompanied by the clinician via iPad. Mental health support on phone with the clinician, and the clinician can contact law enforcement if needed. Crisis responders must involve natural supports to aid in de-escalation. So natural supports such as family. And these are specific to the incident. So the provider must assess whether it's safe to engage with the patient first or with the family first, and what works best for that patient. Establish a specific level of care screening for all to follow. Even during co-response, law enforcement should have allowances to leave the scene, so that mental health may conclude services and provide resources. Recognized crisis providers must be incentivized to handle their own work-related stress and trauma. And specific protocols to first contact, particularly in rural areas when one provider arrives on scene prior to the other. For example, if law enforcement arrives prior to mental health. States should mandate written procedures be created and be available to the public, and it can be adaptive but not prescriptive. Okay, so in regard to networks, we identified the project scope as describing how to establish a relationship between CSBs and private providers, with a particular focus on providers of color to reinforce equitable, patient-centered care, and to ensure there are contracting relationships and community providers who represent the areas they are serving. This may include the development of a sample MOU between a private provider and the regional crisis hub. Make a recommendation and outline for networks and or a coalition with racial and social justice lens, and a strong interest in the success of Marcus Alert, while working with DBHDS to estimate budgetary needs for such a network and how this network would work with CSBs, private providers, and student researchers. Make recommendations for requests for proposals that would support the network and coalition described above, as well as making recommendations for other requests for proposals such as startup funds for crisis providers. In regard to networks, we identified the need for networks as well as coalitions, and there will be some intersectionality there. Some of the recommendations that we make are partner organizations' initial application during call for proposals must include their equity lens and anti-racist statement. Infrastructure will consist of 6 to 8 sites, groups or network leads, and must be specifically defined. Must be a combination of disruptive and cooperative with representation in social work, psychology, human services, ethics, and justice orientation. Must have rural coverage as much as possible to eliminate non-equitable coverage favoring urban areas. One site must have a relationship with each mobile crisis hub, must be clinical or have a close connection to a clinical agency that bills Medicaid or is a training clinic with a licensed supervisor. Must have a relationship or participate in dispatch infrastructure with mobile crisis hubs. All sites must be collaborative, meeting with regularity, either quarterly meetings or an annual conference or both. In regard to the coalition, we identified the need for a coalition, and more specifically, identified the need for a Black-led coalition. As we know, there are significant racial disparities and mental health responses, and significant racial disparities in many other aspects as well. Here we see an organizational chart where DBHDS and DCJS are state stakeholder committee and the 5 regions. So upon implementation, we know that there will be a statewide oversight committee. And also we believe that there should be the Black-led coalition, which will also have oversight for equity at Intercept 0, but also have a seat at the table for the oversight committee as well, so that they can provide a full lens on equity for the Marcus Alert. So again, it's a Black-led coalition. Again, a seat on the oversight committee will be independent oversight for Intercept 0, ensuring equitable responses, and a system of checks and balances. And something that has a board-like formation, and that's something we still have to work on. Okay, so specific steps and risks. So there is severe risk of harm if equity and safety are not achieved at Intercept 0. Society has a rampant history of unjust social structures, and people with mental illness and or disability are among the most marginalized, stigmatized populations. When factoring in race, risks are exponentially increased, with Black and minority populations experiencing significantly increased adverse outcomes as a result of crisis intervention. So with that in mind, we recommend that during the data collecting process and data analysis process, that there's specific attention paid to in regard to race. So this is a heat map, and the heat map is based upon race. You can see the counties in red with the highest amount of Black people in the population. And then you can see that the top population is actually in Richmond for those first initial 5 counties. So it'll be important to see how the Marcus Alert is impacting racial disparities in regard to mental health responses, if the Black population is receiving more equitable access to mental health services as a result of Marcus Alert. Considerations for multiple site implementation must also be made. Here are the first 5 regions for implementation. As previously stated, geography is a big factor as well. And then, of course, we know that there will be an assessment plan as well conducted by DBHDS and DCJS. In regard to equity, some of the components of the assessment plan are to number and description of approved local programs and how the programs interface, comprehensive crisis system and mobile crisis response, number of crisis incidents and injuries to any parties involved, a description of successes and problems encountered, an analysis of the overall operation of any local protocols or programs, including any disparities in response and outcomes by race and ethnicity of individuals experiencing a behavioral health crisis, and recommendations for improvement of the programs. Results from the assessment and written report will aid in development of additional sites. When conducting this assessment plan, we recommend, again, that there be special attention to seeing how this program is impacting the Black community, whether it is improving outcomes or if there is, unfortunately, adverse outcomes. So we must mitigate risks and determine whether those risks were mitigated in the assessment plan. And of course, this whole initiative is to eliminate the de facto law enforcement response to behavioral health response for behavioral health crises. Data should confirm that there are decreased adverse outcomes in racial and ethnic communities and less barriers to accessing care. Okay, that's it. Sorry, guys, I know that was a lot of information. Also, I do want to state that there is a significant amount of recommendations that we have in networks, and it's all going to be condensed into a form so that it can be presented to have those specific criteria for networks. Okay, does anyone have any questions?
Yeah, are you open to questions at this point, Catherine?
Yes, of course.
Well, I just need you maybe to help me clear up a point of confusion first, but I understood your presentation of be focusing on Intercept 0.
Mm-hmm.
But there was a lot of talk about law enforcement in Intercept 0. And it was my understanding Intercept 0 avoided the involvement of law enforcement. And if we try to track that back to the presentation that we had on triage, law enforcement probably wouldn't become involved until levels 3 or 4 in that triage protocol. And the second thing, we already have a lot of mandated training that the department is placed on mobile crisis team expansion. Did your team look at the total, that if you looked at the minimum coverage for everything, what the total training commitment would be in terms of time and dollars, and who pays for that?
Perhaps.
And second, and then another thing that immediately jumped at me when you had on your slide examining the Medicaid rates, over half of the people we provide crisis response to now do not have Medicaid, and so we should not be relying on Medicaid as the principal funding stream for this project. And then comes into play the question of how we network private providers or nonprofits into that scenario, since there's no direct funding stream for them to serve the medically indigent, or those with commercial insurance that don't pay for crisis response. So there's a lot of things I just threw at you, but your presentation was overwhelming and I took notes.
Thank you. Okay, so I'll go ahead and address those. And if anyone else from our subgroup wants to pitch in, please feel free to do so. So the first aspect in regard to training. So I know there was some discussion about law enforcement. So if we don't have equitable practices at Intercept Zero, then what will happen will be non-equitable outcomes. And as we see, this disproportionately affects Black and minority communities. And so that's why the discussion of all providers receiving standardized training is there. So if it is standard across the board, then there is no, oh, I did this training for this specific program through my employer. I did this specific training. It's standardized training, no back and forth. And when the community reaches out and wants a Marcus Alert response, they know what they can expect. And so that's why the discussion of law enforcement is there. So in regard to the prices of the programs, so Paradigm is fairly affordable. So Paradigm is catered to small organizations as well as large organizations, and they price it in tiers. And so it's a very affordable program. It's about $499 a month between one and I believe it's 1 and 20 individuals who need to receive the training. What's great about Paradigm is community leads or CSB leads or provider leads, they can go in and they can adjust the training specific to needs. And so they can have a combination of the live workshops, a combination of the online modules, and then also consulting services. And so it really allows someone to cater to their specific geographic area, their community needs, and any problematic issues that may arise within their organization. In regard to the workshops that were presented, the workshops are more expensive. Visions, we actually have a subgroup member who took part in Visions and can share their experiences. I'm not sure if they're on right now, but perhaps they can share their experiences with Visions. And they did state that they had a really great experience with Visions. The workshops are typically about $1,400. So I didn't find any that were below $1,000, which is why I said that if we have this broad Paradigm training implementation, then there can be these smaller workshops to really focus on specific components that may not have been addressed in that training. So like disability justice and additional anti-racism training. In regards to the disability justice organization that is not US based, but does work in the US, they have very affordable training as well. She actually quoted, I think it was $390. So $390 was pretty affordable. In regard to some of the other trainings that were recommended, so like trauma training and de-escalation, those were also fairly affordable. Trauma training was a couple of $100, so was de-escalation training. And I'm so sorry, that was a lot of information. Can you please tell me if I'm missing something?
Yeah, Catherine, I really think maybe I expressed the question incorrectly.
Okay.
But I'm just wondering if anybody's taken a step back and said, if I were to take all of these options, covering all of these knowledge, skills, and ability areas that your committee, your work group has laid out, what would that minimum set look like in terms of time for training commitment and what the minimum cost that we could expect? And it's clear that that training would be required of everybody involved in the Marcus Alert crisis response system, particularly the behavioral health components and the law enforcement components. So as I'm sitting here and looking at how Virginia has funded this thus far, the immediate bells and whistles that go off is this is not in the $600,000 that's been allocated to each region, not by the guidance we've gotten thus far. And anything that impacted that would blow this up completely.
Hey, John, I can clarify on that front. Yeah, no, this is not in reference to the $600,000.
Okay.
This is more, we have multiple federal lines of funding that are incentivizing investment in crisis services that are either about to start or.
So that's fine. So then we can expect EBHDS to bring some resources to the table with regard to that. And therefore they'll be our partners in making decisions about not the choices that we have, but actually making final decisions on what we're going to be adopting. But again, I would still be concerned about the amount of time that we will, and not that it's not necessary, but what is the time burden going to be? And how would we support that with staff turnover and everything else? And finally, that networking issue to the nonprofit and private community, and how Medicaid may or may not be helpful, and how we would fund nonprofit and for-profit private providers in the community to participate in the crisis network when there's not a clear funding path for them.
Okay, so I want to address first your question in regard to how much time the training will take up. So the workshops are about 2 to 4 hours average. So 2 to 4 hours once a year, that's not a lot of time. That's not a significant amount of time, which is why we recommend the broader training and then the smaller workshops. And we definitely don't think that disability justice should be left out. The IDD and DD community definitely need to make sure that everyone that's responding does have that disability justice component. So in regard to the other components, Paradigm Reach, as well as Paradigm Consulting, and the other aspects that Paradigm offers, it is tailored to that specific region. So we do recommend nothing that's like 2 to 3 hours. We're still having those discussions because a lot of these just came together recently. So there's still that discussion about minimum amount of hours, but Paradigm, if you're doing it online, that can be a situation where it's not a significant amount of time. And then the consulting, majority of the consulting that occurs is consulting with that CSB lead or private provider lead or public provider lead, whatever that situation looks like. So then that they're equipped to be able to change the culture within their organization, which is extremely important. So yes, the training is necessary, as you mentioned, and I know there are concerns about timing, and there may be concerns that, okay, there's a small component in this specified training that someone may be receiving, but again, that's a small component. Obviously, there's change that has to be made because, again, look at the statistics that we just went over. So in order to make change, there has to be innovative ways to be able to bring forward that change. So instead of relying on the systems that are already in place or the things that we have always done, some sort of change has to be made. And we believe that training for all providers is the way to move forward and do that. Oh, yes, Ryan. Sorry, Ryan, I just saw your hand.
No, it's okay. I just wanted to say that Well, thank you, Catherine, for representing our group so well. I really appreciate it. And I know you put a lot of hard work into the presentation. It's a lot to unpack. It's a lot of information. I was typing a chat just to remind people, like, these are our recommendations. And these are where we felt we wanted to start. We understand that all of these things aren't going to be possible in year 1 or year 2, but we need to make sure that we are setting ourselves up for, these are what we think will make change in the state of Virginia. So these are what we think will make change in the state of Virginia. And whether or not we're able to accomplish that in 2021 versus 2025, they still need to be recommended today so that people are able to take it under consideration. And the reason why law enforcement is included in a lot of these, even though it was Intercept 0, we had a lot of conversation about rural communities and how law enforcement is going to still be a primary responder just because of resources. And so because of that lack of resources, law enforcement is unfortunately not going to be able to completely come out of Intercept 0. So we need to equip them with the appropriate training to be able to continue to have improved outcomes at Intercept 0. So that's just what I wanted to add to the conversation. Thank you.
And
Thank you.
I appreciate you saying that, because I've been saying that all along. And it seems to me that those training expectations would be the same going up the continuum, with even perhaps more added as you move to the more law enforcement based intervention. So thank you very much.
And John, I think you mentioned something about networking and how nonprofits and other organizations may be integrated. So one aspect of the Black-led coalition is to be able to provide that connection to those smaller private providers that may be Black-led, that don't actually have these mobile crisis services, that don't receive a lot of incentives. And we know that representation is really important. So that's one aspect of the Black-led coalition as well. And then also the networks and the coalition, that's a really important aspect. We mentioned how there's a lot of competition. So there's a culture of competition. And to be able to change that and to have collaborative work, which is why we mentioned those quarterly meetings, annual meetings as well. In regard to Medicaid, of course, it's understood that not everyone provides Medicaid, but also there has to be special attention paid to the poor community. So the disadvantaged community who may rely on Medicaid. So if there is no inclusion of Medicaid, then you are disproportionately excluding an entire community that may not be able to afford other forms of insurance. And so that would be non-equitable.
That wasn't my question at all, though, Catherine. I'm saying, yes, we serve a large Medicaid population and it's critical. My point, though, is that over half of the people where crisis calls come in don't have Medicaid. And many of those, it's not because they don't have insurance, it's because Medicaid is not their payer. So the whole payment system on a third-party basis gets incredibly complex. And then there still are, as a group of people who do not have any benefit. And you're absolutely right. We need to have provisions for them to receive equitable access to care, the same as anyone would get under this system. So I'm just saying Medicaid itself needs to factor in, but it's not going to fund the crisis response system from that standpoint.
Thank you, John.
That was my point.
Yes, Natasha?
I'm sorry, I thought I lowered my hand, Catherine, but as I do it as we speak, but I really was echoing, I lowered my hand because Ryan really was sharing what I was going to say, which is that, you know, one of the main purposes behind this committee, this group, has been to identify inequities and make recommendations to improve equity. And so many of our recommendations are not going to be all encompassing to fix each issue. but it highlights where there are inequities and disparities and provides recommendations to remedy that. And so I do think that's really important to understand when we're, and I know sometimes when we're having the equity conversation, sometimes we have to flesh that out so that we make sure our group, and Catherine has been very transparent with this from the start, has really operated with an equity lens. So every recommendation that has been made that you see on the presentation has been from a space of equity and social justice. You know, and so when we're having these discussions, especially when we're looking at training, we cannot enter this in a space where there is a divide in training, because we don't want to be the state where someone says, here's where Virginia got it wrong. We don't want that. One of the areas for that would be if there's an inequity in training. And so that, because again, as to cite my sources, like Catherine just said, inequity in training results in equity in outcomes. And so we're working to minimize that. And so I just really wanted to make sure that Ryan shared it, that we just echoed that, and understanding that so many of our recommendations are really, really designed to highlight where there's been some disparities, and then find recommendations to really level that so that we have more equity. I officially lowered my hand now.
Thank you, Tasha. So sorry, Melissa, I didn't see your hand.
Hi, thank you. And thank you for this wonderful report, Catherine. I actually was wondering if you could sort of help me understand in your subgroup what your discussion was in terms of the needs of the IDD community at Intercept Zero. Because somehow I wasn't getting that from the report. I heard a lot about mental illness and substance use. I took a quick look at creating accessible neighborhoods, and it looked like a lot about physical disabilities and chronic medical conditions. And so I just was wondering what your discussion was regarding the IDD community and your recommendations.
Excellent question. So we did specify the need for disability justice training. And the reason we centered in on that organization is because there is just a lack of actual organizations that specifically address disability justice. There was a lot of discussion about peers and those with lived experiences. And so a lot of our conversations centered around lived experiences, which is why the additional recommendation was made to actually try to engage with a lived experience disability justice advocate and have that training from that aspect, because they can provide that lived experience aspect and be able to perhaps overcome some barriers and some inaccurate assumptions that are made on the ID and DD community.
So I just sort of, I wondered if you took a look at the ARC's National Center on Criminal Justice and Disability, because they're actually sort of the national leader in training in this area, and just wanted to recommend that you take a look at them. Because they're located right here in Washington, D.C., and this is exactly their area, their niche. Yeah.
Absolutely. And any additional recommendations we greatly appreciate it.
Yeah, no, I'm happy to talk more about it. One of the things that I've just struggled with a little bit with the Marcus Alert groups is that there is, so even in sort of your introductory slide, when you talk about mental illness and substance use, IDD is not included there, sort of in your introduction. And I don't know if it's being put under the umbrella of mental illness. And although many people do have dual diagnoses, these are two different things with two different sets of trainings and experts and things like that. And so I just want to make sure that it's not being lost in the shuffle here. Kind of interestingly, I was on a Department of Justice meeting this morning and heard that the Ruderman Family Foundation just came out with a white paper that states that disabled individuals make up 1/3 to half of all people killed by law enforcement officers, and that disabled individuals make up the majority of those killed in use of force cases that attract widespread attention. So I just, somehow disability ends up being missing from a lot of discussions, and I just want to add it in there. Thank you.
Thank you. We have a question that says, will any training or consulting include implementation support as well? I am a trauma-informed trainer, and in my experience, the training impact is greatly reduced without support for implementation of trauma-informed culture change within agencies. That's a great question. We are definitely open to any suggestions you may have. We did highly base this on implementation science, so that's why evidence-based and peer-reviewed and systematic reviews. So that's why we place a lot of emphasis on that. A lot of research was done in regard to implementation science, and that's why this presentation was formatted in this way. So yes, absolutely. If that is a gap that needs to be addressed, yes, I think that would be a great recommendation. Are there any more questions? Or would any of our subgroup members like to make any comments? Yes, the slides can be shared.
I just wanted to add that I see like the network and the Black-led coalition component serving as that accountability and implementation piece. So I think that would, and there is it intercepts with the oversight as well and review components. I just didn't want that to get left out of the critical role the network model would play.
Thank you, Chloe.
That's a really good segue to, if there aren't other questions, that's a good segue. We can kind of, in a way, next is the local roadmap work stream, but we can, to have a more cohesive conversation, we can talk specifically about that concept of, these different, committees and oversight and how this stuff will fit together. Anyone want to add anything else here before we do that? Thank you so much, Catherine, and everyone in the work group.
Yeah.
All right. So I just kind of, the slides are underwhelming for the local roadmap planning, but if you had a chance to read the state plan, this is more of a process group. So, the what to react to is kind of what is in that state plan. Let me just get my slides going. Oh, can you guys see that? Okay. So I'll just kind of run. Well, actually, let's no need to run through them. Let's actually just jump ahead. Some of these we can come back to these, but let's go on and talk about that, because I did already notice that in the objections document. Just kind of we've had a lot of general conversations about, like, we know that we want the accountability to be developmental and layered and, process related. We want it to be local and something that's, we've kind of, I think that there's a lot of similarities in how we're thinking about it. But when it comes to that, really putting a pin on it, like, what are we saying? Is this group going to recommend that a board be established? Like, what exactly are people thinking in terms of envisioning that? You might notice that, so at the local level, what the local planning group came to was the idea of, so that at the local level, they'll also have a stakeholder group. And then the idea being that they would continue to meet probably twice yearly to review the data and have a role in the quality improvement. I don't know if this came out of the work stream or if just when I was trying to connect the dots from different things people had said in the first draft, said essentially one mechanism being that group be required to, one thing we sometimes do with groups like this is they'll be required to write a written response and like recommendations, and that has to be submitted as part of the annual report, so that so at the local level that would go to DBHDS, and then kind of the idea was at the state level something similar would happen. So there would be so again, we're kind of getting into the weeds of, like, is this a board? Is this a stakeholder group? What exactly is it? But some kind of entity that is related to this group we're in now, that also has some formal roles, like, for example, if the Black-led coalition, you know, assuming that's in the final plan, that the lead of that coalition would have a seat at that review table. And essentially that entity also would review data twice yearly, and that they would provide a written piece to that final report that goes to the General Assembly. So again, just kind of connecting those dots between, you know, quality improvement and setting goals, but so that to connect that body to not just that they're saying that to DBHDS and DCJS, and we're just kind of free to say, oh, I don't know, maybe, you know, that their stance would be articulated as a document that is part of that yearly report. So that's kind of like where, that's what I wrote into the plan, but without doing a label on, you know, well, what is this group? Is it just this stakeholder group and it just, you know, goes in perpetuity? Do we think something like a board would make sense? So I'll pause there and just kind of see what initial thoughts people have. You can share thoughts at the local or the state level, but if you could make it clear which one you're talking about, that would be great, because there's a lot. It could be easy for us to get very confused between thinking about review at the local level and review at the state level. Why don't we start with a local area? Would one of our initial implementation sites be willing to give some, I know you guys were all in the work stream, but obviously it's all been, you know, pulled together. Any of the local sites willing to kind of say what they think about this concept of, you know, you have the stakeholder group now, the idea that twice a year they would come back together and they would, you know, be given the data to review, including health disparities, and they would be able to provide you a written response and recommendations as part of what you turn in as your final report. Any of the initial areas want to speak on that? Jim?
Sure. I guess my only question on that was, you know, our local group has been meeting pretty regular. We meet every couple of weeks. We didn't pose that to them when people were either assigned or volunteered to the group. So while I think people are very engaged and active and interested in making sure this project progresses to its implementation, it's a very different question to ask them to come back on an ongoing basis over time, and then to switch those people out who have not been at the beginning, I also think can create some additional difficulties. So, well, you know, I understand the rationale regarding the idea. It's kind of now asking a back-ended question about participation that I don't know if I'm comfortable asking of people we asked to participate in.
Lisa, we're just forming our local stakeholder group, and the intent was to have them convene, but more in terms of, again, we hadn't even gotten into the nitty-gritty in terms of what specifics we would be sharing, but the obvious things would be, you know, outcomes, incidents, health disparity information, so demographics, and the like. And I think our challenge is a little different in the Richmond community, because again, my agency's experience is we're serving probably about an 85% African-American population. That could change under these circumstances. But we had not looked at that as like a formal board or oversight body, but more of a partner body to share information and get feedback. I'm going to be really interested to see what's finally adopted in terms of expectations along those lines, and it may require some reshaping of our plans. We've been putting most of our focus initially on our implementation team, planning some of the nitty-gritties that are maybe a little bit detached, but like thinking about, how do we fund a co-response team and how do we tie that to the mobile crisis hub, and how do we address the issue of the voluntary database, and those kind of more nitty-gritty things. But yes, clearly these other issues will have to be addressed to mature that process.
What thoughts do you think, y'all? What about at the state level, this concept of this on, so we know that we're required to have a yearly report. And we know that as part of that, we were required to sort of divide up who's responsible and who's accountable for what, and have this focus on health disparities. And so then, the state plan would be where we would sort of say, what that means to us. So yeah, any thoughts at the state level about what that more ongoing, so DBHDS is required to report on these things year to year. Assuming that we all would like community involvement, community feedback on the plan, the integration of community responses into the overall plan overall, and as time goes on, what mechanism do you all see as appropriate? Because we don't want to rely on just like, my word or something like that, right? So what types of mechanisms have you guys seen work for a plan like that? Any reaction to this idea of an ongoing body that meets twice a year and then provides a written segment of the yearly report?
So,
or if people, sorry, just to weigh in, are pros and cons. If people don't necessarily want to, stake out a position, so to speak, maybe just listing out some pros and cons would be a starting point.
I'm just seeking clarity. So are we suggesting something that is not this existing group?
It would be, so that's kind of one of the questions. Yes. So we could say, hey, we want to formalize this, we want this group to keep meeting. So we're going to kind of ask the members, who's willing to keep meeting twice a year. And, that's definitely one way to do it. Yeah. I think that is, I think that's something that makes sense, but it would probably need like the, to Jim's point, some structure in terms of, these are the areas of stakeholders. If, too many people don't want to be involved in an ongoing basis, we would need to, for example, if we lost CIT stakeholder, we would need another CIT stakeholder, you know what I mean? So something, we would need to put the parameters up, but yeah, that's kind of trying to get some ideas around that.
Lisa, I really would support that, because this group should probably see this baby that's being birthed through the developmental stages. And the other thing, I guess my reaction with our local stakeholders groups and the expectation that they generate a report, I think that might be a little bit of a heavy lift depending on how you constitute your community stakeholder group. But I could see a periodic report submitted by this Marcus Alert team with the input from the stakeholder group added and validated as a way of streamlining that process and making it participatory. So if we actually met with the stakeholders and we took their feedback and we put it in right then and there, and it's kind of like we do with note-taking with clients, where we're doing participatory recording of the chart, so they know what we're putting in their chart. I think we do the same thing with something like this. That might be more plausible.
I would echo, I think what John was just sharing, and I think to Patrick's question that might have been the point too, which is I certainly support having an ongoing team that's meeting twice a year. I would recommend it look very similar to this group because we've seen the start of the data. And so I think it's a bit easier to track it and chart it when you have a working knowledge of it. I was also thinking very similar to John in that if the challenge is the local group sending everything up, perhaps I don't know if there can be almost a subgroup that's really meeting with the local work streams and work groups to identify that data and almost report that back up. And so it just could be that becomes a bit overwhelming for the local groups. But with a smaller stakeholders group, there are certainly individuals who could serve in that capacity because we have to get the data from the local groups in order to really produce it to the state. So that would be my recommendation. If there's if the opportunity is there to limit the threat to the data, it's probably the committee, the stakeholder group going to the local group as opposed to sending the report up.
I'm a little confused, and I guess I'm seeking clarity. I know there is a data group. I guess my confusion is around the larger frame around data and accountability. Obviously, we just heard from Equity at Intercept Zero, and they had some recommendations around accountability and oversight, but we haven't heard recommendations or a presentation from the data group to help this entire planning group understand what's being proposed in the report as it relates to data and accountability. And I really think that would be helpful for all of us to try and have a broad understanding of what is being proposed as it relates to the interaction between local, regional, and state accountability and oversight. Having this conversation outside of an understanding of this broader framework for me is challenging because I don't have a clear picture of what this looks like in the broader sense.
Like what the data points will be. Yeah, and that I actually had that on my list to touch on. I can touch on that really quick, and then I see LaShonda's hand is up. Yeah, so we've been having a number of conversations regarding the crisis call center data platform, and I had kind of written things up based on what I had heard from that group in one way, but once we sort of actually looked at the details, the internal recommendation or the DBHDS recommendation is that we do as much as we can to integrate this reporting into the larger crisis call center platform. That RFP posted and was closed in March and should be awarded soon. And so I think the idea is if we can have, Marcus Alert presence in the development of that platform, that's going to be the best way forward as far as how to get it in a way that's valid and deduplicated and not too much burden on people. But what is in the state report, but what we should have, and that the group can provide a presentation, or unfortunately because of the timeline at this point, you can look at the first draft and see what is in there. And react, and we can have a conversation that way. So you're kind of saying until sort of what this data is going to look like, it's hard to think about the group most appropriate to review it and give feedback. Is that kind of?
Well, I know we had a presenter from the community who's not part of this group talk about what her perspective on accountability, transparency, and oversight is. But we haven't heard a specific presentation and recommendation around what is being proposed. So that's all I'm trying to understand is how these various layers of oversight and accountability relate to each other. I know Ms. Higgs mentioned civilian review boards, and I did see mention in the state plan about the creation of civilian review boards. So I'm just trying to kind of understand how all of this sort of fits together as it relates to data collection, reporting, and oversight among the local, regional, and state levels.
Yeah, I think next meeting will definitely be time to do that. But again, what is in the report is what has made it into the report. With the, that's the place to start in terms of what's being considered for the state plan. But I think we can definitely plan a long conversation about that next time, and then also circle back to this idea of what are the accountability structures, but kind of the details of health information versus events and all of that, what made it into the state plan is into that first draft is as far as anyone's gotten. So that's kind of what to react to at this point. But I can definitely do this at the next meeting in more detail. LaShonda?
I just had a suggestion or a recommendation.
I cannot hear you.
Can you hear me now?
A little
Can
bit.
you hear me, Lisa?
Yeah, I think so. It's a little choppy, but if you can go ahead.
Okay, I was just wondering, would it be possible for there to be a representative from the subgroup? And that way that person will be part of that group that's going to meet every 2 years. And that way the report doesn't have to come from up or down. They will already know the information and will be able to provide that information to the group. Is that possible?
Well, I think in the first couple years when it's the initial areas, I think that would be great. I'm thinking once it's statewide, depending on how the areas break down, it might be too many. I don't know if too many is the right word, but kind of something like that. I think starting there in the first couple of years makes a lot of sense. But others feel free to chime in. And Rebecca, I see you have your hand up.
Yes, I just wanted to say I have a little bit of concern about the idea of an overall statewide accountability review process. Understanding that we are going to have consistent guidelines that are going to be part of the state plan. Each locality is also going to, my understanding, have the flexibility of how to take that and implement it to meet the needs within their community based on what's available, what they need to create, what's not available, where they're targeting some of the problem areas. So I think that's going to be, especially as you referenced, having more and more localities coming on board in future years. It's going to be very difficult for a centralized body at a state level to look at all of those different plans and be able to say, yes, there's consistency there across from an accountability perspective, being able to determine you met this goal, you didn't meet this goal, when in reality it could look a lot different from a growth and implementation process from region to region. Having it be local seems like a better accountability piece, with maybe a statewide piece having a little more consistency and equal implementation or consistent implementation and tracking, and just maybe a pass-fail rather than a grade of other sorts. I'm not sure exactly what.
Yeah, well, I think also one, or at least the way I was thinking about it, is that the state oversight would be more not about the details of the local plan, but really looking at a state level. If on but it could have a local piece, because like, so for example, if on average, X percent of calls are being transferring from 911 to 988, and it's maybe 5% of calls. We've been up and running 2 years, and statewide it's 5% of calls. But then the state group might say, well, look, this locality is doing 10%. This one is actually doing 0%. I wonder what that's about. So it would be more at that. It's not that it would never get to the local level of data, but it would be at that much broader sense of Particularly things like health disparities. In small communities, we're not going to be able to have that fine grained look, but at the state level, we should be able to understand patterns in who's being served. And so it would be more of a data review like that. I don't know if that makes a difference in your opinion or not.
Lisa, the data only allows us to ask questions. It doesn't give us answers. And so I just say that because any way the data comes in or any data you select is going to have to be interpreted and investigated based on what's driving that data. What are the factors affecting that data? And I was hoping when I first heard of this, I thought, oh, we've got real easy systems here to provide data, especially around disparities. And so, I'm hoping that we're going to be able to have a mechanism that painlessly draws data from 911 centers. We already have data that can be drawn from CSBs through our reporting. I know the way I would set up my co-response team, for example, would be in one cost center. So any of their services could be reported in terms of demographics. But then the call center, so we'll have data. And the problem is sometimes those data sources will overlap, but sometimes they're going to be mutually exclusive. So to get the whole picture, it's going to be very difficult because 988 and 911 aren't necessarily all going to be getting the same calls.
Going back to the original question also about the overall roadmap and meeting twice a year and things like that, I really like how alternate transportation as a program with the department has done things, because obviously they had a staggered implementation. Every few months a new region was rolling out. It used the planning regions. And they do a quality assurance council that we're now meeting quarterly in Region 1 because we're established. But at first it was every couple of months, and then it stepped back to quarterly. And then I'm sure it might eventually, we're now talking about merging into a statewide quality assurance with more limited participant now that it's been, we're over a year in since implementation. But it was kind of the staggered approach where in the beginning, there's a lot more direct dialoguing with Dustin and Gail, and they did a great job with data reporting and figuring out trends in the regions and seeing how can we do this and what about this CSB, and then obviously staggering it and stepping it back as they needed to. But I thought that was a really helpful approach to and you can see the increase in the utilization of AT over time that's gotten better, and I'm sure part of that has to do with kind of their staggered approach to how they've been monitoring that. And I like even just calling it quality assurance was a nice way of labeling it.
Thank you. So we're not necessarily going to have time to do a full round. We have 25 minutes left. But I'm assuming that folks have responses. I guess we have two options. I could go through these. I could go through more details of exactly what the local roadmap work stream landed on. Again, all of that is now in the text of the report or some version of it. Again, they didn't each give their stamp of approval to it before I try to put it into words in the document. Again, that's for everybody to react to. So I could just kind of do that, or we could open it up to any general comments people had, or especially making sure everyone understands the objections log and how to use it. Assuming that people do have some more general comments that they want to make. It sounds like the conversation about the accountability framework, people have some ideas, but want to see more details and then react, which I respect that. So if it makes sense, I'll probably stop sharing. And so do want to double check that everybody does understand the objections log. So again, that's the idea of when you do read the plan, that's where you write down the concerns that you have. You can add on to other people's concerns, but don't delete anybody's concerns. You can add recommendations on concerns that exist, but again, don't delete recommendations. And then those that will be assigned as lens readers, those will be people that will actually be providing more fine-grained edits in terms of, for example, if you find bias in language or things like that. Now, if you find bias in language throughout the report, you can certainly flag it as an objection. But for, little minor edits and things, we'll leave that to the lens readers because we don't want that document to be, changing around outside of the 3 drafts. So I'll go on and kind of stop there, see if anyone has any general comments that they want to make or any issues, if there's any more general. I know that I know there has been some difficulty accessing SharePoint, but again, if that's the case, just read the Word document of it, and you can always just email objections. It's just as simple as, this is the objection, and this is the recommendation if you have one. I will probably be circling back to subgroups about objections that are raised that relate to their subgroup. Some of this has already happened. There was a detailed conversation about level 3 in the triage subgroup, and that was in response to what could be characterized as an objection. So I'll probably be, I guess, just kind of reaching out as objections impact different work streams, parts of the report. So I'll open it up to comments there. We do not have any public comment today.
Lisa, it's my understanding that all objections have to be submitted by Friday, close of business. Is that accurate?
Just to get into the second draft, there's going to be 3 drafts total, and that's just for version control. So definitely not like all objections, but if you, there's going to be a new draft that emerges pretty quick, hopefully addressing some of these, bigger, like for example, the equity at Intercept 0, I need to add some of that to the report, different things like that. So yes, there's going to be a second draft, and if you anything you put in the objection log before Friday will make it into either comments or the actual draft. But then the objection log is ongoing. It'll span all 3 drafts. So it's ongoing.
I'm sorry, I just heard you say objections made before Friday will get into the next draft.
Or sorry, yeah, through that timeline. Whatever I said was that, not before. And then, but it's really not, you can make them on Saturday, Sunday, and, well, I guess there's a chance they would get in depending on how many there are. But, they'll definitely be right there for draft 3. So I know that's a very quick turnaround, but since we did say 3 drafts, did want to at least put that out there. Oh man, well, I don't think we've never ended this group early, but if no one has any comments, we could certainly go ahead and do that.
I'm sorry, Atasha, can you give me a call? This is LaShonda. Can you give me a call after the meeting if you have a moment?
Sure, I will send you an email so I get your information.
That would be great. Thank you.
No problem.
All right. Well, I think that that on that we can go on and end if folks don't have anything else. Thanks everybody for the information today. We'll start incorporating things into another draft, and we'll just keep it going. Just keep the feedback coming in, and we'll continue working on the plan. Thanks everybody.
Have a good one.
Have a good one, everyone.